Hello friends, welcome to my YouTube channel TNC Updates, Toxicology and Critical Care. Before starting the video, a disclaimer, the following videos touch various important topics of critical care medicine and toxicology. The videos are not exhaustive account of the disease conditions discussed. The videos derive their content from various standard textbooks of medicine, critical care, toxicology. But as the guidelines change rapidly as per the new level of evidence, the viewers are strictly advised to follow the discretion and advice of treating specialists. Today's case, very interesting case based on post-operative critical care. What is the case? A 40-year-old male diagnosed carcinoma head of pancreas with no comorbidities was posted for a pylorus-preserving pancreaticoduodenectomy. He was taken up for surgery and an enhanced recovery after surgery protocol was followed in the perioperative period. Surgery was complicated by intraoperative hemorrhage due to superior mesenteric artery injury, resulting in around 2.9 liters of blood loss, replaced with 3 PRBC, 3 FFP, 1 SDPC. Hemostasis was attained. His BP was borderline, requiring noradrenaline 0.04 mics per kg per minute to maintain the MAP within normal limits. Now, what is the enhanced recovery after surgery protocol? It starts from the preoperative period. Pre-admission counseling reduces patient anxiety. Fluid and carbohydrate loading attenuates catabolic stress, preserves muscle mass. Avoid prolonged fasting. It decreases insulin resistance. Selective bowel preparation. Don't induce too much diarrheas and all. Prevents dehydration and metabolic and electrolyte derangements. Thromboprophylaxis. Often ignored because it can lead to prevents thromboembolism and it can lead to various other complications. Avoidance of pre-medication. Avoid too much of sedation. Expedites postoperative recovery. So intraoperative variables, antibiotic prophylaxis. It prevents surgical site infections. Use mid-thoracic epidural, regional analgesia wherever indicated. It spares opioids, thus expedites recovery. Short-acting anesthetic agents expedites recovery. Minimize the drain insertions. Improves postoperative early mobility. Maintain euvolemia, maintain tissue and organ perfusion. Minimal invasive surgery, use transverse incisions, less postoperative pain and early mobility. Temperature often ignored, maintains adequate metabolism. Postoperative multimodal non-opioid analgesia enhances mobilization, prevents ileus. Avoid nasogastric tubes. Prevents postoperative atelectasis, fever, respiratory tract infections, improves patient satisfaction. Postoperative nausea and vomiting prophylaxis improves mobilization and early enteral nutrition. Early removal of catheters. Don't delay it if it's not indicated. Early enteral nutrition. Early return of bowel function, maintenance of anastomotic integrity with decreased postoperative complications. Early mobilization, prevention of venous thromboembolisms and early return of gut function. There is something called PGDT, perioperative goal-directed fluid therapy. Although there are no definitive guidelines for standardization of specific physiological parameters, endpoints, devices or fluids for PGDT, international consensus amongst various societies have accepted PGDT as a standard of care in their national health policy recommendation. So what is this perioperative goal-directed fluid therapy? It can be summarized in this chart. So what they say is measure stroke volume variation and cardiac index. Start with this. If the stroke volume variation is more than 10% and CVP is less than 15 millimeters of mercury, give fluids 3 ml per kg bolus over 5 minutes. If stroke volume variation is still less than 10%, then go for cardiac index. If stroke volume variation is still on the higher side, then fluids have to be given more. So there are two lines. Either you go in the dobutamine side if the stroke volume variation decreases. If the stroke volume variation is still on the lesser side, then you have to go on the dobutamine side, cardiac index. If the stroke volume variation is on the more side, it is more, then go for CVP. CVP's rise is still less than 3, then go for fluids. Multimodal analgesia. Prolonged opioid use can lead to tolerance, withdrawal. Other adverse effects include hypotension, bradycardia, ileus, nausea, vomiting, urinary retention, constipation, delirium, and hyperalgesia. Alternative strategies include paracetamol can be used up to a maximum of 4 grams per day in divided doses. Caution in liver dysfunction. Use up to 2 grams per day. Dexmedetomidine, ketamine, and renal analgesia epidurals. So our case, couple of hours later, the patient starts desaturating and requires increased FiO2 of 0.6 to maintain 94% saturation, and the partial pressure to FiO2 ratio is less than 150. The BP continued to remain borderline, requiring norepi support to maintain MAP of 65. Chest X-ray done shows bilateral consolidation. Echo done, good LV function. Diagnosis of trolley was made and the patient was ventilated with lung protective ventilation strategy. So what is trolley? It's an immunologically mediated clinical condition leading to non-cardiogenic pulmonary edema, which usually develops within 6 hours of blood product administration. So it can be a suspected trolley, acute onset within 6 hours of blood product administration. PA by FiO2 definition includes the same status of ARDS, which we use, same criteria of ARDS. So PA FiO2 ratio less than 300 millimeters or SpO2 less than 90% on room air. So radiologically, bilateral pulmonary infiltrates on frontal chest X-ray. The cardiac part is normal. No evidence of hydrostatic pulmonary edema with pulmonary artery occlusion pressure less than 18 and CVP less than 15 millimeters of mercury. No definite temporal association with an alternative cause of acute lung injury. Possible trolley similar to suspected trolley, but possible temporal association for an alternative cause of acute lung injury exists. Delayed trolley. Same for suspected trolley with onset within 6 to 72 hours of blood product administration. So, what are the recipient risk factors? Recipient risk factors for trolley are circulatory shock. The patient is already in a stressed state. Hematological malignancies, massive transfusion when you are having, liver transplant recipients, high peak airway pressures, high interleukin 8 levels, positive fluid balances, end-stage liver diseases patient, smokers, chronic alcohol abuse. Transfusion related risk factors when you are using high plasma volume components, plasma from female donors, blood products from multiparous donors, transfusion of components with high titers of anti-HLA antibodies and components with high titers of anti-HNA human nuclear antibodies. Immediate management, stop transfusion if ongoing. Notify blood bank of the transfusion reaction. Send transfused blood bags to blood bank. Send patient's blood to blood bank for cross-match analysis. Blood bank protocol, investigate blood products within 6 hours of reaction. Antibodies, check donors for anti-HLA, anti-HNA. Determine HLA-HNA antigens of recipient and complete antigen antibody cross-match. Treatment is supportive, prevent hypoxemia, hemodynamic support, diuretics have no role, routine use of steroids not advocated, novel therapeutic strategy that target neutrophil sequestration, the first hit, and HLA-HNA antibodies, the second hit, are under research. Actually, the trolley is a theory which is based on two mechanisms. That first is the sequestration by the neutrophils in the lung epithelial cells, which release various mediators of inflammation. So the lung epithelium gets primed, and second hit is that when the transfusion occurs, the blood or the blood products which are transfused, they act on the already primed lung epithelium. That results in lung parenchymal injury and resulting in trolley. So, summary of general care needed in a patient on ventilator in ICU. So, the mnemonic uses fast hugs bid. So, F stands for feeding, A stands for proper analgesia, S stands for sedation, T stands for thromboprophylaxis, head and elevation of bed, ulcer prophylaxis, proper glucose control, spontaneous breathing trials whenever indicated, bowel management, indwelling catheter management, and de-escalation of antibiotics at the earliest. So returning to our case, on postoperative day 1, the patient continues to be hypothermic and hypotensive, requiring noradrenaline 0.1 microgram per kg per minute. His ABG revealed lactate of 4. Urine output has been less than 0.5 ml per kg per hour over last several hours. CVP 6 millimeters of mercury. Now, the obvious question is, how do I assess the fluid status and fluid responsiveness in this patient? So the answer will be, since our case is a post-operative patient with no comorbidities and all the above signs like lactate, like blood pressure, like norepi going on, all these suggest hypovolemia. We should immediately assess the drains for any ongoing bleeding, and replace the losses. Our patient should receive a bolus of 500 to 1000 ml of crystalloid immediately before evaluation for any fluid responsiveness. To evaluate fluid responsiveness, one needs to assess the overall clinical picture, which includes history, clinical parameters, static and dynamic indices of fluid responsiveness. So there is a clinical pearl. Static parameter easily available such as CVP cannot be used to assess the volume status of this patient, but it can be used as a safety parameter for fluid challenge. Since our patient has no comorbidities, normal heart, a reasonable safety endpoint for fluid challenge can be set as CVP of 10 millimeters of mercury. So if the CVP does not increase with initial fluid challenge, but target MAP is achieved, then one can wait and reassess after some time. If, however, the safety endpoint is reached before the target MAP, then one must stop giving any further fluid boluses and reassess again. Alternatively, dynamic indices such as passive leg raise test, stroke volume variation, platysmograph variability index, aortic velocity time integral, and end expiration occlusion pressures can be used. So these are the dynamic indices, if available, and which can be used if certain conditions satisfied, they can be used. So passive leg raise test is the only dynamic index which can be used in spontaneously breathing patient and is also applicable in the following situations where these dynamic indices cannot be used. So these dynamic indices cannot be used in which situations? They can't be used in spontaneously breathing patients. They can't be used in patients with arrhythmias. They can't be used in patients with low respiratory compliance. They can't be used in patients with protective lung ventilation, that is trolley patients, ARDS patients, where we use tidal volume less than 8 ml per kg. patients with open chest. So in these patients, for fluid responsiveness assessment, you can't use dynamic indices. You can use PLRT, or what else we can use, we will discuss. So PLRT, passive leg raise test, involves auto transfusion of approximately 300 ml of fluid by changing the position of the patient from semi-recumbent to one of recumbent one with lower limbs elevated to 45 degrees. The effects are monitored with real-time cardiac output. So fluid responsiveness is that when you give a bolus of fluid, there is a change in cardiac output by more than 15%. There is another measure which is catching up now, which is called pressure venous minus arterial carbon dioxide. That you measure the carbon dioxide pressure in venous blood and arterial blood through ABG, and what are the principles behind it. The fundamental principle of measuring the PV minus ACO2 lies in its association with Fick's equation, which shows that carbon dioxide generation, that is VCO2, is equal to cardiac output multiplied by difference between venous carbon dioxide content and the arterial carbon dioxide content. So what is the VCO2? VCO2 is carbon dioxide generated. How much carbon dioxide is generated? It is cardiac output multiplied by the content of venous carbon dioxide minus content in arterial carbon dioxide. Now, since it's always difficult to measure the content, what is easily measurable is the pressures, partial pressures. So we are measuring partial pressures in ABGs. And since the relationship between the carbon dioxide content of blood, CCO2, and the partial pressures is curvilinear and more or less linear at physiological ranges, the above equation can also be written as, that is, the C can be substituted with P, and we can have the curvilinear part can have a coefficient K. So carbon dioxide generated is equal to the difference of the venous and arterial carbon dioxide pressure differences multiplied by cardiac output. So cardiac output is actually inversely proportional to the PCO2 gap. So if we along the x-axis we have cardiac output, and along the y-axis we have the difference PCO2 gap, venous minus arterial pressure carbon dioxide. So as the cardiac output goes down, the pressure difference, that is PV minus ACO2 gap, increases. So if the cardiac output is decreasing, PV minus ACO2 increases. What are the practical uses and how do I interpret it? The normal value of PCO2 gap is around 5 millimeters of mercury. The PCO2 gap reflects the adequacy of venous blood flow in clearing the carbon dioxide load irrespective of tissue metabolic demand. Increase in VCO2, that is increase in carbon dioxide generation secondary to aerobic or anaerobic metabolism, will not increase the PCO2 gap if there is a corresponding increase in cardiac output to wash out the carbon dioxide load. Similarly, any decrease in cardiac output resulting in a decrease in tissue perfusion results in carbon dioxide stagnation and increase in PCO2 gap. Studies have shown that high PCO2 gaps are associated with poor outcomes in patients with septic shock and post-surgical patients as well. So what are the limitations? There can be errors of measurement, cannot be used in spontaneously ventilating patients where hyperventilation can cause an altered CO2 gradient. Normal values don't rule out ongoing tissue hypoxia. The gap is insensitive to determine tissue hypoxia secondary to regional microcirculatory changes or hypoxic hypoxemia. But these are the important things which can be derived from the PCO2 gap. Normal values rule out low cardiac output. In that case, one must look at other ways of improving tissue oxygenation. And abnormal values along with low CVO2 and raised lactates. If you have three things, that is an increased gap which is more than 6 millimeters of mercury of carbon dioxide difference is there in the pressure between venous and arterial blood. Along with that, you have got a low SCVO2, central venous oxygen, and you have third thing, raised lactates. This suggests a definite low cardiac output. If a definite low cardiac output is suggested, either you will go for fluids or you will go for dobutamine. So fluid responsiveness, to summarize, what is the practical approach? Combined analysis of PCO2 gap, SCVO2, lactate, oxygen saturation, SaO2, and the ratio of PCV minus ACO2 to the PA minus CVO2. That is the carbon dioxide gap pressure divided by oxygen gap pressure, which theoretically is equal to VCO2 minus VO2. That is carbon dioxide generated divided by oxygen consumed. That is what we call respiratory quotient, is a marker of global tissue hypoxemia which correlates with increase in cardiac output by more than 15% after volume expansion in septic patients. So this is a very beautiful chart I have drawn by inference that these are the parameters which lead us to definite something in practice. So what are the various things which we do practically? Practically go for lactate first. Lactate can be measured by drawing a venous blood sample. Lactate can be measured through ABG. If lactate is normal, there are no serial values of lactate showing an increase above 2 milliequivalents, then it's normal. Then no fluid responsiveness is to be assessed. It's a no intervention zone. If lactate is abnormal, then we go for second thing, SCVO2. SCVO2 can be less than 70% or more than 70%. If SCVO2 is more than 70% and PCO2 gap, then we look at, after SCVO2 we assess the PCO2 gap. For both situations, that is decrease of SCVO2 and increase of SCVO2, we can have an increase or decrease of PCO2. If SCVO2 is more than 70%, oxygenation is okay, but PCO2 gap is more than 6 millimeters, plus we are having a lactate which is increasing. So two things are there, but one thing is okay. So two things are abnormal, lactate is abnormal and PCO2 gap is more. Then we go for checking a fluid responsiveness. If fluid responsiveness, we have to check, there are two things we can do. If fluid responsiveness is there, give fluids. If no fluid responsiveness but PCO2 gap is more, then you have to go for dobutamine and assess the cardiac index. If SCVO2 is more than 70% and PCO2 gap is less than 6 millimeters. So oxygenation is okay, PCO2 is okay, but lactate is on the wrong side. So if PCO2 gap is normal, that means we need not worry about the cardiac output part and the fluid responsiveness part. Here, the only thing which we have to manage is the oxygenation part. So, oxygenation part is by SaO2. So, SaO2, if it is less, you have to increase the PEEP. If SaO2 is less, you can increase by HB by blood transfusion. So SVO2 is less than 70%, you have to go for increasing of oxygenation by increasing the ventilatory PEEP support or increasing HB by blood transfusions. But if PCO2 gap is more, you have to assess the fluid responsiveness by targeting dobutamine or by giving fluids. If SCVO2 is more than 70% and PCO2 gap is less than 6 millimeters of mercury and lactate is on the higher side, then it can be a microcirculatory or mitochondrial defect. Here manipulating microcirculation will likely be ineffective. So everything is happening at the cellular level. Cellular metabolism, it is the center of the whole play. The key concepts in cellular metabolism are closely related to oxygen delivery and oxygen consumption. Oxygen delivery DO2, oxygen consumption VO2. Normally, oxygen consumption is independent of oxygen delivery, as increases in oxygen consumption are maintained by increase in oxygen extraction. So three things are there: oxygen delivery, oxygen extraction, and oxygen consumption. So in stress state, when oxygen delivery decreases, oxygen consumption doesn't increase. Oxygen consumption will not decrease because oxygen extraction will increase. If, however, the oxygen delivery decreases below a critical threshold, then anaerobic metabolism ensues. Sepsis causes microcirculatory aberrations that result in development of anaerobic metabolism at higher than normal levels of delivery of oxygen. So if I have to summarize this whole things in chart form, what will be the chart? So I plot delivery of oxygen on x-axis and oxygen consumption on y-axis. So let us move from right to left. I am moving like this. I am moving on in a normal state. If we start from left to right to left, so oxygen delivery is decreasing as I move from right to left. Oxygen delivery is decreasing, but the oxygen consumption is same. But this is a critical point at which there is a sudden fall in oxygen consumption. So this is the critical point in normal physiological state. But what happens in sepsis is that this critical point shifts towards the right side. So when I move along this direction, that is decreasing DO2 levels, then this critical threshold is achieved at a much higher level of DO2. So many a times it happens that the patient is having normal oxygen levels in ABG, normal PCO2 gap in ABGs, but he is having an increased lactate. So that patient clinically will be in a very bad state, but he will be having normal oxygen levels. He will be having normal PCO2 gaps, but very increased lactate. So that is because delivery of oxygen is there, but the consumption has come to a critical point much before. So ABG will detect normal oxygenation level, but the lactate will keep on increasing because oxygen consumption is not taking place because of poor extraction at even a higher level of delivery of oxygen. So, what are the clinical pearls? Although lactate is a marker for anaerobic metabolism, there are many confounders to raise lactate levels in a patient of acute circulatory failure. So, when you are having beta adrenergic stimulation, when you have got various inotropes, epinephrine going on, decreased hepatic perfusion, liver patients, decreased activity of pyruvate dehydrogenase, mitochondrial diseases, then it has been found that lactate clearance is a better marker of tissue perfusion than isolated values. Then lactate clearance, don't use isolated values but use serial levels. So returning to our patient, the patient's lung condition gradually improved with a reduction in oxygen requirement, sedation stopped, and the patient given weaning trial with TP's trial after 72 hours. He was later extubated after a successful weaning. So there was a role of daily sedation interruption. And let's talk about SBT, that is spontaneous breathing trial. SBT is a strategy to determine patient's readiness for extubation. Commonly used strategies are you give a TP put the patient on CPAP, then automatic tube compensation, inspiratory pressure delivered to overcome the tube resistance. The duration of SBT ideally should be more than 30 minutes and less than 120 minutes to avoid tiredness in 24-hour criteria. What is a successful SBT? That the patient should be extubated after a successful SBT. A visibly comfortable looking patient with no signs of distress and increased work of breathing. Presence of adequate cuff, resolution of conditions requiring, so the root cause should be corrected, absence of excess tracheobronchial secretion, adequate oxygenation and lung mechanics, that is SaO2 less of 90% or PaO2 more than 60 millimeters on FiO2 of 40%. PaCO2 less than 50 millimeter of mercury, or there's a less increase, the increase should be less than 8 millimeter of mercury. pH should always stay above 7.32, or if it decreases, shouldn't be more than 0.07. Respiratory rate should be comfortable, less than 35 or less than 50% increase. So respiratory rate, the prior which was on CPAP, it should, when you give a T-piece, it shouldn't increase more than 50%. So RSBI, the frequency, respiratory rate divided by tidal volume in liters, should it is a ratio, it should be less than 105 breaths per minute per liter. So hemodynamic stability criteria for SBT. So patient should be having heart rate less than 140 per minute, or increase shouldn't be more than 20%. Blood pressure less than 180 millimeters, or increase shouldn't be more than 20%. Absence of any arrhythmias. Patient should be assessed every 24 hours proactively to increase the probability of weaning from ventilatory support. Intraoperative and postoperative measures to prevent postoperative respiratory failure. Use regional analgesia where possible to spare opioids. So use epidurals. Lung protective ventilation. Tidal volume 6 to 8 ml per kg, and plateau pressures of airway on ventilator should ideally be less than 30, if not 30, less than 20, if not 20, then actually should be actually less than 30 centimeters of water to prevent any volute trauma. Application of PEEP to avoid atelectotrauma. Avoid using high FiO2 to prevent absorption atelectasis. Ensure adequate intraoperative and postoperative analgesia. Avoid excessive sedation. Maintain normovolemia. Avoid blood product transfusions where possible. If patient is ventilated in postoperative period, use suction above cuff endotracheal tubes. So saccade tubes. Semi-recumbent position 45 degrees always unless contraindicated. In major abdominal surgery, don't rush extubation, as non-invasive ventilatory support in these patients hampers abdominal recovery. So go for CPAP support with tube inside till you are sure about extubation. Early mobilization, early physiotherapy and breathing exercises. So our case, the patient finally shifted out of ICU with simple oxygen mask and 2 liters of oxygen per minute, chest physiotherapy, early mobilization, breathing exercises advised. Thank you so much for the patient hearing.